some optic neuritis questions. Can double vision from multiple optic neuritis attacks be irreversible? And kind of how do you deal with double vision beyond using steroids?
I think I'll handle that since I'm the neuro-ophthalmologist up here. First of all, double vision is not going to happen from optic neuritis. So optic neuritis is going to cause vision loss, and it will cause portions of the vision, that is the visual field, to be lost, but it won't cause double vision, seeing two things instead of one. So one thing is, if you have an MS attack and get double vision, what's being affected is the motor control of the eyes. So essentially, whether your eyeballs, your headlights on your car, so to speak, are aimed at the same spot. And if they aren't, one eye is seeing at a certain location the object, and the other eye is seeing it at the other location. And that is a neurologic MS cause of double vision. If you're having double vision, and perhaps it is something that is only from optic neuritis, it may be that because of your vision loss and your brain's desire to look off to the side around the area of vision loss, you're going through a portion of the cornea that is warped or essentially has astigmatism, and that can cause monocular. Close one eye, still have double vision, monocular double vision. That's not directly an MS cause, and that can be treated in a number of different ways, mostly through contact lens or glasses prescription.
Can the circuitry in your spine and brain be improved to actually regain balance and improve functioning of limbs?
I can take that one. And so I think the question about can things get better? And I think the answer to that is always yes. I think one of the things that we do very well as humans is when we don't do something well, we tend to do less of it, right? Like, so my leg is weak. I'm not using that leg as much when I'm walking. My balance is weak. I'm walking less. And one of the things that happens when we do things like that is those areas that are responsible for that, for balance, for example, in this question, is they tend to become less robust pathways because we're using them less. And so one of the things that we can really do, or we should really focus on, is when we feel areas that are weak or less strong than they used to be, is really focusing in on that exercise. So for example, when our balance is off, focusing in on retraining our balance centers, because then we're not getting that, again, 1 + 1 is 3 situation of it doesn't work well, and I've also lost the functionality I had.
Is there evidence to support more tight joints in MS patients? For example, if you just have a tight hip on one side, and then kind of in the same vein, do injection medications deteriorate joints, causing pain in specific joints?
So I guess you can always have, it's very common to have differences side to side in strength and function in a limb. And so we wouldn't think that tightness, I think that was the first part of the answer or question, would come directly from MS, but kind of to Anna's point, if you're using a leg less, then you might also have some tightness because you're just moving it less. And then the second part of the question was about injections.
Yeah, did the injection medications deteriorate joints?
Oh, like a steroid injection I would assume, maybe?
Or
like
Copaxone?
Or maybe Copaxone, I don't know. So, people do get steroid injections in their joints for pain sometimes, and so that could be part of the question. And I don't know the evidence very well on that, but you typically don't want to receive a lot of those.
Yeah, probably from the medications, probably less so. I think there's a little bit of wear and tear that can happen from just if you have a leg that's weak, your hips get off balance, and so you're not being efficient in your walking, and you get more of the kind of bone on bone wear that would otherwise happen. For some of the tightness, you might end up with spasticity, which is more tightness for the muscles more so than the joints. And so if that question was kind of directed to that a little bit, that can follow from MS lesions. There are a lot of stretching and trying to kind of help strengthen can kind of help with some of that. Muscle relaxers would be kind of the other strategy that we can use from a treatment perspective.
On the treatment side of things, if baclofen is not really helping for someone for spasticity, are there other things to try, and does magnesium help?
I can take an initial stab at that. So it might. A lot of times the problem that we have with some of these conditions is that it's hard to separate out. Like we use spasm for things that we might separate out into things like Charlie horses, restless leg syndrome, spasticity, tonic spasms, and all of them are treated with different medications, and stretching might help some more than it might help others. And so sometimes how you do with the drugs kind of helps you try to sort out like what it was. Sometimes it's very clear and obvious. Sometimes not so much. And so you kind of end up having to try things. Magnesium is cheap, easy, and pretty well tolerated. Might give you a little bit of diarrhea, looser stools. Most MS patients tend to be a little bit constipated. So it tends to be a really good place to kind of start. Within muscle relaxers, there's a few other muscle relaxers, and sometimes you see that people tolerate some of the other ones better than they might do baclofen. So cyclobenzaprine or Flexeril, tizanidine, or other options that would be good. Stretching can kind of help with that. But if you're looking at tonic spasms, you might need some of the seizure medicines such as carbamazepine or Tegretol, or some of the other versions of that. Restless legs might respond to dopamine agonist like pramipexole or Requip, and things like that. So it's important to kind of sometimes keep trying things if things aren't working.
I might add, the only other thing to add to that list is Botox injections can sometimes be really helpful for spasticity, particularly if there's spasticity in particular muscle groups. The nice part with Botox is it lasts a long time. You're not really adding on an extra pill, but it does depend on where the spasticity is.
We had a lot of questions about stem cell. Where are we with the research? Will it cure MS? Can it treat MS? And is there government regulations that stand in the way of pushing studies forward?
I can take a stab. I think more to come. When we talk about stem cells, it's important to kind of recognize that there's many different ways to do stem cells, or kind of what we sometimes kind of will refer as stem cells. You can have a full bone marrow transplant. That's kind of like the biggest way to do. You take out your entire immune system, you replace it with somebody else's stem cells. Sometimes you'll see sort of like stem cell light options where you just kind of add in some stem cells from other people and don't really take out part of your immune system. And I think there's certain centers that can make a decent profit out of some of these procedures. So I always recommend to kind of say, hey, using that procedure, what's the data that you have around this? When we talk about stem cells, there's an implied piece, I think, or at least for me, there is, about repairing what's fixed. And the reality is there's very little evidence for that so far. What we're seeing with a lot of that approach is to kind of try to say, hey, could this be a treatment to try and prevent relapses? The big trial for that is called Beat MS. Dr. Corboy leads our efforts for that study here. And it's in the process of getting recruited. As far as government regulations kind of limiting things, it gets a little bit difficult because there's no difficulty now because they're not really using pure stem cells. They're using sort of the stem cells from other people. So a little bit kind of farther down the path. But it's making it difficult sometimes to recruit people because the requirements to get into those studies is that you have to fail sort of a lot of times high efficacy therapies, have very aggressive MS to levels that we just don't see because if you have some disease activity, our drugs now are pretty decent at taking out relapses. And again, relapses versus progression is important to kind of distinguish here. But from a relapse perspective, it's hard to see patients with the level of activity that allows you to get into a lot of those trials, which is part of the requirement a lot of times from the FDA to kind of allow those trials to go on. So it's kind of a plus minus answer for that.
And just to add to that, some of the studies that have been done, again, smaller numbers, but really looking at this comparison of highly effective immunotherapy that we use now and looking at some of the stem cells, usually autologous, which is where you're using your own cells. They really haven't seen a huge difference in terms of outcomes. And so, of course, thinking about risks and benefits of what are the risks with some of these medications versus the risks with a stem cell transplant. And we often worry about sometimes some of these risks, including death with stem cell transplants. And does that make sense in the context of each individual patient?
To highlight that a little bit, so there's a center in Mexico that does a ton of these, and they have a paper with I think 1,000 patients or something like this. Part of the challenge is that they do this by doing chemotherapy. You get your cells, then they give you rituximab, and then they look at the outcomes over a year. If you skip the first two parts, the chemo and the stem cells, we know that rituximab, a dose for a year, works really well at the relapse level. So do you need the other parts to this in order to get the benefits that they're showing? Probably not. And so this is kind of where we're at a little bit of, is it really helping, or is it just the whole process that you're having that's helping with controlling relapses?
Dr. Maniago, we had a lot of questions. We had a general question of devices that might be used or treatments for foot drop and walking. And then we had a couple of specific devices mentioned, the Psionic sleeve, a hinged knee brace, kinetic tape, and neuromuscular electrical stimulation.
Yeah, so that's a lot. But there's a lot of different technologies for improving foot drop specifically. It's a pretty in the grand scheme of what it takes to walk, it's a pretty simple motion and therefore a pretty direct target. And so there's everything from traditional bracing. I think I showed a picture of an ankle foot orthotic. There are electrical stimulation devices as well. I think like the walk aid and the Bioness. It's one of those things where it's good to trial any of those devices, right? There's not a one size fits all for everybody with those. And so that's, I think, a case where it is important to evaluate the cause of your walking problem, whether it's, foot drop in an isolated sense or foot drop along with like weakness of the whole leg, in which case some of those devices don't work quite as well because you're having trouble lifting, maybe from the hip. But getting that individualized evaluation, I think, is really important. But there's a lot of different options.
I'll throw in the newest kid on the block is probably the Neuro sleeve or the Psionic device. And we are working, and I think we just got approved potentially, although it's not up and running, to be sort of a test site so people could actually come in and try it at the hospital, at the clinic. So that's something that I think is exciting. It's helped some patients. It may not be for everybody either. It might be a little bit harder to put on than some of the walk aid or the Bioness, but it stimulates the muscle versus the nerve. So it works a little bit differently. So it might be helpful for some people. It's a little bit cheaper. So I think, new devices are constantly coming in, and I think it's worth to kind of explore those options and have discussions. If we forget to bring it up in an appointment, bring it up to us as well. Because sometimes we forget.
And then the other thing is sometimes these devices become more helpful depending on what your intention is or what you're going out and doing. So, of course, most of you have probably had some experience with motor fatigue, which is I walk maybe 5 feet and I'm okay, but it's that second set of 5 feet where I really start having that accentuation of that foot drop. So some of these devices, some of these braces might be things that you say I have in my back pocket, maybe not for my day-to-day activities, but if I'm going out, I'm doing something that's more labor intensive, I'm doing something in the heat, it might be a good thing to have in the back pocket. So we're really reducing falls or catching that foot and falling.
On the subject of fatigue, how do you gauge when it's beneficial to push through fatigue in favor of physical activity and when you should rest?
I can take that one. So fatigue, really common in MS. About some of the studies we've looked at, about 85% of MS patients have fatigue. And the question of when do you push through and when do you not is a hard one to answer. So one of the reasons we think fatigue is so prominent in MS is because we think the primary pathways that allow you to do the functionality that you normally do are impacted by a lesion. And what happens when you're doing that is you're recruiting alternate, less robust pathways to do that same activity. And so you're using some multiplier of more energy to do the same task. So one of the things that exercise does is allows you to make those ancillary pathways more robust. So in the studies that we've done with fatigue, looking at medications, looking at cognitive behavioral therapy, looking at exercise has been the one thing that has been demonstrated to be the best treatment for fatigue long-term. So finding a balance where I'm doing exercise, I'm helping myself long-term with that fatigue, but I'm not doing so much where I exercise on Monday and then I can't do anything for the rest of the week. So it's a little bit individualized, but overall, I mean, exercise is never bad for you long-term and certainly not in MS.
Yeah, and I just want to add to that, like I think I talked about this a little bit, but that idea that a lot of people have it in their head that they need to get 30 minutes of exercise at a time or 45 minutes of exercise at a time and end up pushing through and exacerbating fatigue. And what we've really seen in the literature is that you can do shorter bouts of exercise and it can be just as effective. So it's important.
On Dr. Alvarez's presentation of possible new diagnostic criteria, if these new criteria are adopted, are some people going to be undiagnosed?
I think we'll have to wait and see what the new criteria look like. I don't think there's going to be things that kind of come off from it. I think if in the past we ran into issues where like sometimes you need to have, you know, for details like 9 periventricular lesions, and then they went to you just, you know, maybe needed 1, and there was talk about going back up to like 3 or 9 or something like this. That's something where all of a sudden like the bar got raised. I think what we're going to see is more stuff being included. So potentially like adding the optic nerve, which to be honest, is stuff that we already include. Like, you know, it might not meet the formal criteria for MS, but it would meet the Alvarez criteria for MS, you know, that kind of stuff. And so I think the replacement of the light chains would would kind of just come in instead of the oligoclonal band. So it's just easier ways to measure some of these things and less to remove things. Just to make a comment about undiagnosing MS is that it's common. There's some studies saying that, you know, it's as high as 40%. I don't think it's that high, but, you know, if you've seen me in clinic, I will often say that there's a chance that I might be wrong, and at every visit we reconsider that diagnosis. And some people, the chances of it being MS is 99.99999%, but I would never really tell you that it's 100%. You know, we need more information. There's you know, like if you looked at the dates for NMOSD, it wasn't that long ago that this came out from MS, and it's our second most common disease. You've listened to some of the presentations from Dr. Piquet on sort of some of the other antibodies that are associated with MS around MOG. I mean, these are antibodies that are coming out fast and furious almost every year. So we're learning a lot about these conditions. And I think sometimes it just means that we can end up on the right treatments. You saw that there's a lot of the treatments that we're using for some of these conditions that don't necessarily help people with these other conditions. So I think it's important to kind of just, hey, I don't need to be obsessed with the name of the disease, right? But am I on the right treatment? Really, that's, I think, a bigger question. And sometimes that guides a little bit of kind of our counseling around drugs, some as well.
Can you define what MOG is?
Similar to NMOSD, where there's an antibody to acylphorin 4, This is a disease that is associated with an antibody to myelin, to MOG, to a protein within myelin called MOG. And it has another set of characteristics that would sometimes meet criteria for NMOSD, but it has certain characteristics that we look at it that make it different. Sometimes you see sort of some overlap in some of the features, but it's associated with a different antibody, and that antibody became commercially available when, Jeff, was that like 5 years, 6 years ago?
2017.
17. So, I mean, again, very new kind of diseases that are kind of getting pulled away from some of the other diseases that we used to evaluate.
So I'll add, having sat through the definition of multiple criteria, both for NMOSD and for MOGAD now, we're trying to use antibody studies and the specificity of them to help us separate disorders, but we still have to consider the clinical nature of the patient in front of you, because all antibody tests have a small risk of having a false positive test done. And so no one falls onto a needle in the office. No one gets accidentally tested for MOGAD when a doctor miswrites something and it comes back positive for MOG IgG or comes back positive for NMOSD, that is aquaporin 4 IgG. And someone says, I know you have this disease. If you don't have the presentation, we have to carefully consider whether this is a false positive test. So all of our criteria involve having a clinical episode, having the corresponding features of that disease, and it's cemented by the presence of the antibody. And then how we understand how those antibodies work to drive the disease forward clues us in on the immunology. In one instance, as I told you about earlier, we were able to use the antibody to understand the immunology of NMOSD and come up with new therapies that are very specific for that disease. Some of them overlap with one of the therapies we have for MS, but the others don't. And similarly for MOGAD, we're going through the same process right now, where, for instance, B-cell depleting therapy doesn't work nearly as well for MOGAD as it does for MS and NMOSD. So all of this is an iterative process, and we have good models for MOGAD. We've been using them for years. We just called them MS when they weren't. And so now we're rebalancing the scales and learning to address it appropriately.
And are the tests for these antibodies something that people can seek out on their own, or do they have to do it through their doctor if they suspect they have something other than MS? What's their next step?
I think you can't do it at home. We haven't gotten to the point of having the COVID test that you're going to rip open and swab your nose and, be able to test for MOG IgG or aquaporin 4 IgG. Those tests, however, and how they're done are being revised constantly in order to maintain their high sensitivity. We don't want to miss cases, or their specificity. We don't want to accidentally call cases that aren't. And right now, our best way of doing it requires live cells that are grown in the laboratory and then reacted to from the antibodies that are in patients' blood. So that takes a laboratory to do it. And it's actually not all laboratories around the world can do it when it requires these live cells. We're trying to adapt it so it doesn't require the live cells and doesn't lose all that sensitivity and specificity, so that we can have quick blots and dots and things on paper, and we could add a drop of blood and do all these tests. That would be great because it would open access around the world. It would also be great because the turnaround from testing your blood to getting an answer is a lot longer when it requires these live cell assays. So you can't do it right now at home, and we don't want people to do it right now at home. In fact, right now, when we made the diagnosis of MOG and established the initial criteria, we actually wanted to stop physicians from testing for it as often as they did, because if you didn't have a strong inkling clinically for the test, the amount of false positives could label people inappropriately. For instance, a person with optic neuritis in the state of Colorado is about 10 times more likely just by having the optic neuritis to have MS than they are to have MOGAD. And if you then took all comers and tested them for MOG-IgG, given the very small 5% false positive rate of that test, half of your MS patients that you tested would be false positive for MOGAD, and you'd be making the diagnosis incorrectly. So in some ways, we don't want you testing at home for the same reason, because much more often than not, it would be false than true. And so that's why we're, trying to not only have it in an office and for all those other technical reasons, but also trying to get physicians to be aware of the presentation to make sure that a test that turns positive is much more likely to be truly positive than falsely positive.
This is one of those areas with misdiagnosis, because we do see the wrong testing, the old testing kind of being done, especially for MOGAD, because it was known that a decent percent of MS patients actually have antibodies done that's positive to MOG if done kind of by the old ways of doing it. And so it's this new way to do this that has really cleaned that up. And so that's kind of what we're still learning about and trying to clean up in the process of things.
We had a large amount of questions relating to cognition. So I'm going to try to group a couple of them together. Cognition is very difficult to measure. What are there physical indications? Does it show in an MRI scan? What are some things that people should be on the lookout for in order to portray this to the doctor?
Good question. I think if there's things that you're noticing, especially cognitively, one of the most important things is to write down examples or write down kind of what you're feeling, because I'm sure everyone here has been in that situation where you're sitting in the room with one of us and we're asking you these questions and it's just all of the questions in your brain just kind of disappear. So making sure you're writing those things down, especially when we're thinking about cognitive episodes, because you might forget them by the time you come to the clinic. One of the tests that I talked about really briefly that can be really helpful is that neuropsych testing, that 4-hour chunk of testing. Now, one of the biggest limitations with that test is the very first time you take it, it is comparing you to peers of a similar age and gender in the general population. So if we have individuals that say, hey, I got a doctorate, or I have achieved a certain level of education, or I am very mathematically savvy, or things like that, it might create this sense of I'm doing really well on these tests and I don't detect an abnormality in any of the circuitry or any of the testing. Where it can become helpful is if you say, hey, I do this 5 years in the future and I'm comparing to myself and I see really where that decline is in myself. One of the things that we try to include when we do MRI scans, particularly here at the university, is looking at brain volume levels. Now there's